A 62-year-old hypertensive man presents with sudden onset vertigo, difficulty in swallowing, and slurred speech. He has got hiccups, hoarseness of voice. From the history, where will you localize? Vertigo usually, if it's a true vertigo, it is a brainstem symptom. So whenever somebody comes off with complaints of vertigo, differentiate between is dizziness by asking whether there is a feeling of rotation is there or feeling of movement is there. Then only you call it as a true vertigo, and it indicates brainstem involvement, that is either the vestibular or the brainstem connections are affected. So second symptom in this patient has got a swallowing difficulty. Swallowing difficulty can be due to an involvement of the palatal muscles, that is 10th or 9th nerve weakness, and in addition he has got hiccups. Hiccups is an interesting symptom that occurs in brainstem stroke, and the hoarseness of weakness or hoarseness of voice can again be explained on the laryngeal palsy related to the 10th nerve palsy. So here anatomically the structures involved in this patient is most likely involvement of the brainstem. If the onset is sudden, so we'll consider that is most likely a vascular or a demyelinating illness. Age is 62, so this is a vascular problem. So these are the two questions that you will ask initially. Where is the problem? Then followed by what is the problem? Here where we consider it as a brainstem problem. Now we go to the examination. He has got on examination has got palatal palsy. That is when the patient was asked to say the palate move towards the right side. This means patient has got a left-sided palatal palsy. He has got a left Horner syndrome. The miotic people with a partial ptosis on the left side. Has unsteady gait and has got difficulty. He has got ataxia, left limb ataxia, and loss of pain and temperature on the left side of the face and right side of the body. So we'll localize, see the findings once more. So you can see the patient has the palate is moving towards the right side. That means that a 10th nerve palsy, and the site of lesion is most likely it is an LMS lesion. So it is located in the medulla. Second symptom is mentioned is a loss of sensations on the left side of the face, especially pain and temperature. So pain and temperature lost on the left side with the loss of pain and temperature on the right side. So this is a crossed finding. So crossed finding suggests brainstem, and the tract involved is spinothalamic. So patient has got involvement of the spinothalamic tract. In addition, you can see the ptosis on the left side with the meiosis that indicates patient has got a Horner syndrome. So we have discussed the tracts or structures affected. So now we go into where is the problem. Before that, you look into the brainstem. So this is the brainstem is actually continuation of the spinal cord. So this is the medulla followed by the pons and then the midbrain and the diencephalon of the thalamus. So this is the, and here you can see the brainstem. So this is the cerebellum and this is the brainstem. This is the pons and this is the medulla. Hope this point is clear to you. So we have located the problem in this patient to brainstem. So, and where is the problem? In the brainstem, where is in the medulla. So in order to understand, you should use the rule of 4. In the medulla, there are 4 midline structures. They start with the M. One is the motor nucleus of the 12th nerve. Second is the medial longitudinal fasciculus, which is concerned with the eye movements. Medial lemniscus, that is the great sensory acquisition, continuing as the sensory. That is the medial lemniscus, is concerned with the touch, vibration, positions, etc. And the medullary pyramid. So these are the midline structures. So in this patient, there is no weakness, no involvement of the 12th nerve, there is no eye movement abnormalities, or there is no internuclear ophthalmoplegia, there is no loss of proprioceptive or the fibers that is passing through the posterior column. So the midline structures are not affected. So this part is affected. We call it as a medial medullary syndrome. So medial part of the medulla is not affected, and that is why there is no weakness. It's a very conspicuous, very important point to remember. Somebody comes with ataxia and some symptoms suggestive of brainstem. Look at the motor. If the motor is not there, it means the medial part is not affected. So now look at the lateral part of the medulla. It contains four structures which start with S. They are the spinocerebellar pathway, the fifth nerve, the spinal tract of trigeminal, the sympathetic, and the spinothalamic tract. So these are the four structures on the lateral aspect. In addition, there is an inferior cerebellar peduncle, and there is the vestibular nuclei that is coming here, and the 10th nerve. So remember, the four structures laterally start with S. They are the tracts. And these tracts are, I will repeat, spinocerebellar, the spinal tract of trigeminal, the sympathetic, and spinothalamic. Regarding the spinothalamic, remember that the spinothalamic tract is crossed in the spinal cord. If you remember the spinal cord, the sensory fibers entering, pain and temperature fibers, they relay, and the second order neuron cross to the opposite side and ascend as the spinothalamic tract. So these sensations, this spinothalamic tract is carrying sensations from the opposite side of the body. That is why you get a crossed sensory finding. The sensory fifth nerve, spinal tract or trigeminal, is on the same side. So you will get a ipsilateral facial dissociative sensory loss with a contralateral dissociative sensory loss. So that is what we have seen in this patient. Hope you understood the. So all of you should try to draw this picture. So remember, easily you can remember an apple. Draw the cross section of the apple. This will be something you draw like this. So this here comes the gracilis nucleus, the cuneatus, and here is the inferior cerebellar peduncle. And here remember the fifth nerve nuclei, the spinal tract, and the spinothalamic tract. And here is the medullary pyramid, and here is the olivary nucleus. Here the gracilis and the cuneatus, and the vestibular nuclei. Vestibular nerve is coming here, and the sympathetic tract and the nucleus ambiguous. So in this patient, we have got a lesion somewhere here that is producing the symptoms. That is the lateral medullary syndrome. The involvement of the spinocerebellar tract and the inferior cerebellar peduncle produce ataxia. The fifth nerve spinal tract produces the facial problem. That is, you have got dissociated sensory loss ipsilaterally, and the involvement of the spinal tract trigeminal produce the sensory findings on the contralateral part. So dissociated sensory loss on the opposite side. And the involvement of the nucleus ambiguous produce the palatal weakness. So you have seen that the palate has moved towards the right side. So the patient has got a left-sided palatal palsy. Involvement of the sympathetic produce the Horner syndrome. So involvement of the sympathetic produce these partial ptosis. So this is the way we explain the findings of involvement of the lateral part of medulla, that is the lateral medullary syndrome. So I will summarize this. Dysphagia and hoarseness, hiccup, nucleus ambiguous, vertigo, nausea, vomiting, and nystagmus, the vestibular nuclei. Ipsilateral facial pain or temperature loss, spinal tract to trigeminal. Contralateral body pain and temperature or dissociated sensory loss due to lateral spinothalamic tract. Ataxia is due to inferior cerebellar peduncle. Ipsilateral Horner syndrome is due to the descending sympathetic fibers. So we explained all the clinical findings, and now see this picture again, and right again I request you to draw this picture and learn. So here you can see the inferior cerebellar peduncle, the descending sympathetics, the nucleus ambiguous, the spinal tract to trigeminal and the spinothalamic tract, and this is the MLF, this is the medial lemniscus, and this is the motor pyramidal tract. Pyramidal tract is not affected. That is why in a patient with a lateral medullary syndrome, you will not get any weakness in the typical lateral medullary syndrome. So what is the provisional diagnosis in this patient? Provisional diagnosis is lateral medullary syndrome, left side. And what is artery which is affected? It is usually the posterior inferior cerebellar artery, or sometimes it is the vertebral artery in majority of cases. So this is a summarizing. This is the picture you should always keep in mind. That is Horner syndrome on the ipsilaterally, ipsilateral dissociative sensory loss, ipsilateral ataxia, the ipsilateral tendinous palsy. And on the contralateral, you get the dissociative sensory loss due to involvement of the crossed spinothalamic tract. Hope this point is clear. And this is the picture that is usually the dreaded picture regarding the medulla at the level of the olive. So if you simply remember the midline structures, you can easily draw first draw the cross section of the apple, then the medial, the 12th nerve nuclei. Here comes the MLF, and here comes the medial lemniscus, and here comes the motor. All four structures in the midline are due to motors, and start with the not motor. All these are starting with the M. You can easily remember. Lateral we have already discussed. And this is how you explain or remember in a MRI picture or in a imaging. Again, you remember the midline structures and motor nuclei, MLF, medial lemniscus, and the medullary pyramids. Here comes the olive, and this is the inferior cerebellar peduncle, the spinothalamic, spinocerebellar tracts, the spinal tract of trigeminal and sympathetic go close by. And here the nucleus ambiguous. So I hope you have understood the salient features of lateral medullary syndrome, dividing into the medial medullary and lateral medullary. The most important finding, remember, Horner's on the ipsilateral, tendinous palsy ipsilateral, facial sensory, that due to involvement of the fifth nerve sensory tract on the ipsilateral echo. And ipsilateral ataxia, already I have mentioned. Always in any patient coming with vertigo, make the patient sit and see whether there is instability. Second, you do this, at least do the finger nose test. Many times, lateral medullary syndrome is missed in the emergency room because of lack of this simple test. Hope you have understood. Stay tuned for further videos for localization of brainstem. Thank you.